Good morning. This is Jane Gerberding. I'm the nurse consultant with the HCP program and the local medical home consultant with the Colorado Department of Public Health and Environment. Welcome to our webinar on mobilizing partnerships to impact medical home policy. And we're going to have several guest speakers. So glad you could join us, and happy May Day on this snowy day if you're in the Front Range. I'm going to pass this over to Annie Guo, who is our technical guru, and she's going to give you a few instructions about how to participate in the webinar in the chat room.
Okay, good morning. So we have two options for you to participate and interact with us. So one is to type in your questions and comments, so you can see there's a chat box there. And then the other option is to speak through the audio. And the way we're going to do that is you should see a hand tool that represents raising your hand. And then on our end, we can unmute your line, and then you can ask your question through the phone line. So either option is fine, and then we will facilitate the questions throughout the presentation. So feel free to ask any as we go. Thank you.
So first, I'd just like to have introductions about people that are in the room here at CDPHE, and then also those of you that are joining the webinar off-site. So we have our technical assistants, Stephanie Lauer and Annie Guo, and then myself, and
Rachel Hudson, Children, Youth, and Families Branch Director.
Jenny Muntali, HCP Unit Manager.
Molly Benkert, Denver.
And who's joining us by phone? We have Amy Antuna, Brenda Tuttle, Ginger Hilliard, Greg, I'm going to not say this correctly, Greg, I'm sorry, Renowski, Ida Wade, Jenna Ward, Kathy Bolajak, Kendra Mulch, Stacy Sloan, and Searing Dorji. So, sorry, I was asking you to talk and you're muted, so I'll tell you who's on the phone there by myself. So, welcome to the webinar. Our objectives today are that our participants are going to become aware of complementary strategies, which are Objective B, C, and D in the Medical Home Local Action Plan for the Medical Home Priority. Participants will understand what we mean by medical home policy in the Local Action Plan and receive some local examples. And also participants are reacquainted with the Medical Home Priority Resource Document. You can't get out of a learning circle that I'm facilitating without looking at the resource document. And I just want to say here that the concepts that we're going to talk about here today that impact policy could really be transferred to any one of your MCH policies. So for instance, if you have the early childhood obesity prevention as one of your other priorities with MCH and an action plan, that this policy vein or policy subject could be transferred to those other priorities that you have in your local community. So I'd like you just to put your policy hat on or your policy glasses and think about what kinds of policy implications you might be addressing in your local action plans and how you might be affecting your organizational structure or your local policies. So I'm just reminding you that these concepts can be used in other priorities through it with MCH. It's not letting me go forward, guys. Click on the back. Okay. Okay. So I'm just reminding you of the local action plan, the Medical Home Local Action Plan, and this was given to you as an attachment, and you all should be fairly aware of this specific local action plan. I'd like to refer you to page 2 of that, which was a handout, and on that page 2, you will see that in the about the third way down the page, it talks about the core strategy, and the core strategy of the medical home plan is mobilizing partnerships, or Objective A. A local public health agency may also choose to include one of these more complementary strategies, Objectives B, C, or D. And so that's what we're going to talk about today specifically, is how your objective A is perhaps complementary to a B, C, or D priority. The core strategy, as I mentioned in the local action plan, is mobilizing partnerships. If you look at that same page, page 2 on your local action plan, you'll see that there are 5 goals in the local action plan, goal 1 through goal 5. And goal 2 is specifically written about the mobilizing partnerships. The goal 2 is, states improved communication, collaboration, and enhanced support networks amongst medical home projects and initiatives in whatever county you reside in. And so I'm just reorienting you to the local action plan and where these objectives are and what the core strategy is, which is talked about in that first section of the local action plan. Secondly, I'm going to remind you of our favorite document, which is the Reducing Barriers to a Medical Home Approach, and it's called the Local Action Planning Resource Document. On here, I'd like to have you open to page 5 of that document, which actually highlights Objective B. Again, I'm going back to these complementary strategies, Objective B being assessing policy, Objective C being adding the consumer voice, and Objective D having providers supported. But what we're going to concentrate this morning on is specifically Objective B, assessing policy, and that correlates with Goal 3, that policies that support a medical home approach are strengthened and or maintained in your county. So Objective B, wow, that little circle just went around. All righty, Objective B. Now I'm back to page 5 on your resource document. And this, I'm reading directly from page 5 on your resource document. It says, what do we mean by medical home policy? Medical home policy, for the purposes of this action plan, is any principle or rule that guides decisions. This goes beyond legislation and includes organizational practices and procedures, program eligibility criteria, interagency standards of communication and or referral. The policy or policies on which a local public health agency may choose to focus on is contingent upon the specific barrier to a medical home approach selected by the local stakeholder group. So then on page 5, you'll flip it over to page 6. It talks about some examples of some policy assessment questions that you might be asking your stakeholders when you identify a policy that needs revision. So I'll let you just read through those on page 6, 1 through 7. This is on your attachment if you're not following. It's on the attachment that was sent to you, is reading actually what policies were identified. So I'm just making sure that you can read through those and talk about some of the questions you might ask yourself and your stakeholders, and that we have provided you some samples of those. And then below the 7 questions are some examples of a medical home policy change. And these examples, I think, are really great to think about because they actually are focus areas that you have in your your local action plan and your medical home local action plan. And so the examples that are listed here are creating a policy to guide appropriate referrals for early intervention that is shared across referring organizations across the community, or that you're creating an MOU between local hospitals and community-based organizations to strengthen the transition of your NICU population through discharge to the community, or that you're establishing agreements between organizations who provide care coordination services to clarify target population and eligibility criteria in order to minimize duplication of services. Again, this is in your resource document on page 6. And just wanted to make sure that you realize that this document kind of guides you through some of the things that you might be asking yourself and your stakeholders about if you have a policy implication to your local action plan. So now I'm going to turn it over to Dawn Joyce, and Dawn is giving us a prior example from Boulder County when she worked there, and she can introduce herself about her role there in Boulder County. But this isn't specific to Boulder County Medical Home Local Action Plan. This is some medical home work that was being done in Boulder County as the health department being a partner. And Dawn is now our health services unit manager as of about systems unit manager as about 5 weeks ago. So Dawn, take it away.
Great, thank you. Well, good morning, everyone. Thank you so much for joining us today. As was just mentioned, the example that I'm sharing today comes from the work that was done in Boulder County from 2008 through about 2012. Some of the work is certainly continuing. I'm no longer involved in it. We did indeed start this work as a pilot site for CDPHE at that time, and then were able to secure other grants and local funding to continue the work with time. Can I have the next slide, please? Great. So what I'd like to start with is a brief overview of the kinds of partnerships that were actually mobilized to lay the foundation of the medical home initiative work that happened in Boulder County, and then from there to go into an overview of the steps that we took and how those led to various policy interventions, then concluding with 3 specific examples of various types of policy that and how we approached it. So one key to success was definitively that our medical home initiative was a collaboration among 3 different county departments. I facilitated it and worked for Housing and Human Services. We also had very heavy involvement from the Department of Public Health as well as Community Services, in addition to our County Commissioner's Office, which was indeed key to have the County Commissioner, policy analysts involved, because some of the policy we did work on was indeed legislative, and that was a key link then to be able to do that. The next slide, please. Thank you. In terms of the committee itself and the mobilization of partnerships, in addition to county departments and the alignment among those, we also had both of our federally qualified health centers, which for Boulder County is Clinica and Salud, an array of different health organizations, including Kaiser, which is one of the main additional providers here. In addition to clinical providers, both the Medical Society as well as the Independent Provider Association, as well as additional family physicians and specialists that weren't involved in either of those other organizations. We also had funding partners at the table that was certainly key to the ability to continue to do the work into the future, because they then understood the value of the work and voluntarily offered funding to support it, and a number of additional organizations, which if I can have the next slide, please, it will show you the details. What was very crucial was that in terms of each of these organizations, we always had the actual decision makers at the table. That certainly, in our experience, was crucial in terms of our ability to then later actually affect change in terms of policy, whether that was organizational policy or legislative policy. So for each of these, for example, for Clinica, it was Pete Liebig, who's the head of Clinica, that was at the table. That was crucial because then the individuals that were participating in the conversations were actually the individuals who could help recognize the barriers and then had the onus of responsibility to actually affect a change. So it allowed us to avoid having to go further up into an organization to actually affect a change. If we decided something in this forum, we had the appropriate individuals that change could actually take effect nearly immediately. If you don't have those levels of relationships or levels of partnerships, certainly it can still be effective, it just will take longer. And we certainly always viewed it as these individuals voted with their feet. They found this forum to be very valuable, and they continued to attend it on a monthly basis. If they stopped attending, then we would have known that it wasn't actually valuable to them. There, of course, was no requirement for them to be there. They were there voluntarily. So once we had established these relationships, the next slide, please. what we did, well, really what we did to begin building the relationships was to actually define what did medical home mean for Boulder County. So we're all familiar with the various criteria that's been adopted in Colorado. In Boulder, we looked at whether that encompassed everything we wanted it to here, and we decided to add one additional component, which was to ensure that individuals continued to have access to care regardless of their coverage status actually changing. The next slide, please. Additionally, as is illustrated on this slide, we chose specifically to focus on Boulder County as a medical neighborhood, so to look at how our systems intersected with one another as opposed to just medical homes within one particular practice. As we did this, we looked through the criteria, next slide please, and actually did an environmental scan where we looked at for each component of a medical home what resources were currently available, what was missing, what opportunities existed, and what did we want to prioritize. It was absolutely crucial that we started here with we developed the relationships, which definitely took time. Then we actually looked through at what was currently happening in our community. Because we had the local perspective, we were able to recognize what was going well and what was currently functioning as a barrier to having children, which was the population we were focused on, actually be able to access a medical home. I think actually that this is one of the most crucial pieces in terms of ever being able to affect change in the policy arena. You need to make sure that you actually have the perspective on the front lines of the individuals who are interacting with families and systems on a daily basis. They see the barriers that exist, and then they're able to actually articulate those, share them with us, like each of you, I'm sure, see this on a daily basis, or your staff members do in terms of what's actually happening, as do other partners in your community that you've brought together. So at first it was absolutely crucial to recognize those, and then within that we were able to say, okay, for this barrier, how could it best be addressed, which for us often went to addressing something through a policy manner. May I please have the next slide? So I'm going to illustrate that in this slide at a high level, and then the following slide will go into more specifics in terms of different kinds of policies and how we actually address them. So as we went through and understood what was working really well in our community in terms of the medical home and what wasn't, one of the barriers that definitely was recognized was the absence of 12-month continuous eligibility for Medicaid. We had significant movement of children between Medicaid and CDPHE Plus, or Medicaid and no insurance, or Medicaid and a private insurer. And that created significant difficulties in terms of continuity with the same provider in the same system. Similarly, it was recognized that there was a proof of pregnancy requirement. So a woman comes in, would like to have coverage because she's pregnant, and it has to have proof that she's pregnant. Well, she can't get proof from the clinic because she doesn't have any insurance coverage. That's why she's seeking insurance coverage. So one of the things we definitely recognized was that it would be ideal to actually get that requirement eliminated. And other states, such as Louisiana, have just chosen not to actually implement that requirement. They figure that if a woman isn't actually pregnant and is saying that she is, well, she probably needs the mental health components of the coverage anyway, and that's not likely to happen as it is. So they're willing to take that risk to the state since you have a certain buffer in terms of how accurate you have to be with your eligibility. So what you're seeing here is just some of the various examples as we looked at what was happening on the ground, what we were able to recognize. If I can have the next slide, please, we can go into the specifics. So what I wanted to illustrate here, as was previously mentioned, is that when we think about policy, immediately our minds can go to legislative policy. And I do indeed have an example here of some work that this group did in that area. But really, policy is much, much broader than that. It's anything that's actually affecting a change at the system level. So rather than just changing something for one person, we're actually changing it then for the entirety of a population that intersects with a certain system. So for example, organizational policy, one of the things that was recognized here by the group was that there were challenges initially where patients couldn't actually get into our federally qualified health center on the same day, even if they really needed that same day appointment because of the medical circumstance. Because we had the right relationships within this forum, we were able to then put a call into the head of the organization, let them know that this was happening, bring it to their attention, and they were able to change their policies internally to modify that. Yes, they took care of that particular individual or individuals who it arose as an example of, but then also they were able to change the policies within their system to open up more same-day appointments based on certain medical needs. So it actually modified their scheduling processes. The same thing happened with an additional clinic in terms of the absence initially of any feedback mechanisms. So various individuals working on the front lines would be hearing the negative experiences that some clients were having. There wasn't, however, a channel for those clients to actually verbalize their experience so that it could affect change. So we were able to work with the clinic to actually open up additional channels for feedback, while then also working at the point of enrollment for clients to better understand how to share their experience. So those are a couple of examples in terms of organizational policy. And I think that a lot of policy that actually will come to be affected will tend to be organizational policy, because it's about how our FQHCs interact with our hospitals, with our healthy communities, et cetera. And we can often affect change in those areas and very much streamline and improve the experience. This particular group also worked in terms of on legislative policy. So one of the barriers or challenges that was identified when we did our environmental scan, which definitely didn't happen in one day, it happened over a period of months because it was very detailed and thorough. But one thing that was identified was that it was certainly a challenge, as many of you may be aware, that at that point in time, if a family was at a certain income level and had a 4-year-old, they would be covered by Medicaid. And if they had a 6-year-old, the 6-year-old would be covered by CHP+. So as a family, they had the difficulty of navigating multiple insurance systems, which didn't result in effective usage of their time and often didn't result in good utilization of care, period, because of confusion. That was one thing that was acknowledged or recognized by this group. That difference is referred to as the stair step. About to what we did, because we worked with our commissioner's office as well, is that we actually put something on the legislative agenda that existed for the county, specifically asking to advocate to have that barrier removed. And indeed, in 2011, Senate Bill 008 came up, and because of the forum that existed within Boulder County's medical home, we were called on to testify and to really be able to share firsthand, this is the kind of experience that our families are having in terms of how they access coverage and care and how they utilize that care and what it means for the impact on the actual families who are affected by this differential. So we were able to share that in the legislature and help advocate for the bill, of course, with many, many, many other groups who are advocating for it as well. And we're able to see that get passed, then went on to actually advocate for it to get implemented, which is finally being implemented now. So that's one illustration of the legislative policy. Oftentimes that can take a long time. For us, it took about 3 years for that piece before it actually went through. But we worked on other things in the meantime and had the policy folks that were at our table actually take that and advocate for it over those years, and then let us know when we could actually be of assistance. And the last piece I'd like to share today is about affecting policy by actually working to change processes within state agencies and advocate for that. So for example, one thing that this group recognized was that there is a whole type of funding called Medicaid administrative claiming that isn't currently accessible within Colorado, with the exception of school-based health. Apart from that, Colorado doesn't currently have the appropriate channels open to actually allow us to leverage this funding. And what the funding exists for and is utilized for in many, many other states is specifically all of the efforts that have to happen between when you reach out to someone to get them enrolled in coverage, they just have to be potentially eligible, to when you actually get them in to the point of care. So this could be care coordination, transportation assistance, translation, et cetera. So much that we know has to actually happen to ever get someone into the clinical setting. So there is opportunity through the feds to actually have that funded on a 50-50 basis. So as a state or local entities, we would pay for half of it, and then the federal government allows us to pull money down and pay for the other half of it. We certainly recognize at the local level the need for that kind of funding to be able to support that type of work because it just wasn't adequate. So what we did was a significant amount of research to better understand what was happening in other states and how they were utilizing it effectively or ineffectively, and then actually advocating with, in this case, the Departments of Healthcare Policy and Finance and the Department of Human Services to actually try to get those channels of funding opened up. And this is something that's currently underway, even though it was indeed started back in 2008. So it's been a long process, but we're getting closer. So my hope is that those examples give you a little bit of a sense of the variety of policy arenas that can be engaged in, because certainly for Boulder County, it was very effective, and we definitively did bring a policy lens to everything that we did to try to affect the greatest change. Next slide, please. So that's it. If there's any questions or suggestions, they're certainly welcome, or maybe we want to hold dialogue for the end. I'm not certain. I'll leave that to the moderator. Thank you.
Thanks, Dawn. Does anybody have any questions? We can unmute you here if you put your hand up. If you have some questions for Dawn about her work in Boulder County and the different levels of policy that she defined. Anybody have any questions? Thanks, Dawn, so much for your participation and your great work.
Thank you.
Our next speaker, oh, questions. Okay, good. Just a minute, we're going to get your questions answered here.
Kelly, we see your hand is up, but I don't think you've put in your audio pin, so we aren't able to unmute you.
Okay, now it did.
Okay.
It works
Okay,
now.
Kelly, can you say something?
It's saying that I'm unmuted. Is it true?
Now
Okay,
it is.
yeah, now you are.
Now
Yeah.
it was.
Hi, Kelly.
Hi,
Would you like to
guys.
ask Dawn a question?
Yes, Dawn. That was extremely helpful. Thank you. This is Kelly Teeter from Denver Public Health. So I wonder, I had a characterization that I would make if I was telling someone else about your presentation. I was wondering if you could tell me how far off or on the mark you would say it is. So if I were to tell someone about your work, I would say that it sounds like you did a lot of work to have a certain capacity or readiness to participate when opportunities then arose. I mean, I know you weren't purely getting ready in the hopes of opportunities. You had certain work you wanted to accomplish. But it sounds like a lot of your success had to do with the fact that you were at the ready as a group with knowledge and relationships and so on. And then when opportunities rose, like the different federal or state opportunities, you were prepared to participate. Is that a fair characterization, or would you say it differently?
Can you hear me?
Yeah.
Yes.
Great. So I would say that is true just for the policy example. So, for the legislative example. So in terms of actually affecting legislative change, we certainly were very proactive initially in having the bill ever even come into being because of it having been recognized, but then it taking a long time, and during that time just being at the ready for the time period at which we could then actually affect change. But in terms of the other pieces, that was all very, very proactive. So something would be brought to our attention. We met on a monthly basis. So something would be brought to our attention in terms of, for example, the example with the federally qualified health centers and the difficulty with scheduling. And we would then address it, and usually it would get addressed within like the next month or so, if not faster. So the rest of it was actually pretty proactive because we had the right people at the table. We could do that. If we didn't have, so in that case, yes, we had to become very ready by building those relationships and building trust, because initially, for example, the FQHCs were fearful of Kaiser's involvement because Kaiser they felt would only take patients when they had a payer source, but then wouldn't treat those patients when they were uninsured, which is problematic for the FQHCs because the FQHCs rely on the payer source to be able to then treat the uninsured, and they felt that it was better for the community. That kind of thing took a long time to resolve for everyone to realize that we actually did have a common goal and shared interest and weren't threatening one another. I would say it probably took like 6 or 8 months and a lot of very sensitive conversations to build that trust. But once we had that trust and had done the initial recognition of what the challenges were, then we were able to be very proactive. The other piece that was key in it was to continue to have feelers out on the front lines. So for example, even though this particular committee had all these very high leadership levels represented in it, we all kept the pulse through our staff members on the front lines in terms of what was happening and what the current challenges were as they were evolving, so that then we could raise them within the next meeting if that was appropriate, or if necessary, we could put the appropriate calls into place immediately to get something impacted. So I actually think it was a bit more proactive than that, with the exception of the legislation. Does that make sense?
Yeah, that's very helpful. Thank you.
Okay, thank you.
We have a question on the in the chat room, and it says, can we get copies of the policies that have been either drafted or approved? Dawn?
Oh, that might be a hard one now. I'm no longer with Boulder County, so I could certainly see what I currently have. There's a couple of things that could be shared that have actually been shared previously in the larger forum that exists for the medical home within CDPHE, so I'm happy to share those. Some of them were, for example, shared policy points that various organizations had. So in terms of legislative policy, Clinica has its own legislative agenda. The hospitals have theirs, Boulder County has theirs, et cetera. So we would come together and create a shared areas to understand those overlaps, so then we would know how to, who to reach out for when certain opportunities arose in the legislative world. And then the other pieces, I don't know how helpful they would be without being actually involved in the form, in that we have lists of what we consider to be like the low-hanging fruit, what the barriers were and how we could address them. But they're not in the most, one, I don't know if I still have copies of them, and my position hasn't been replaced at Boulder yet. So that makes it a little bit challenging. And then two, it may or may not be helpful for you in that the format was created like very much for internal members as opposed to, that were familiar with the conversations, as opposed to for external audience. So I'll look and see what resources I have, and if I think anything would be helpful. If not, I'm happy to have additional conversations. But there's a little bit of a challenge right now with access to the information.
That question was from Kendra Mulch. I'm sorry, Kendra, I don't know which county you're in. This is Kit Carson, sorry. Yeah. And so maybe we can actually give you Dawn's direct number or vice versa. And not that it wouldn't be helpful to all our participants, but we could connect the two of you and make sure.
Certainly, and the other piece that I can definitively share, though, is much of what we identified is included on an annual basis if it hasn't already been passed into law in Boulder County's legislative agenda. So I certainly can share that in terms and highlight the sections that are helpful. So most of it is within human services, and some of it's listed under public health. But that might actually be the most helpful, and I'm happy to share that with the group as a whole, or just to share it with you, Kendra, depending on people's interests.
Thank you. Good questions. Anyone else want to? We can take more questions as well, but we're welcoming your questions. This is an interactive learning circle, and we're wanting you to learn from one another, and that's the whole premise of these. And so, please keep the questions coming. Our next slide. I'm going to try to get in there again, guys. We're going to move on to Vanessa Boyd. Vanessa is going to give us, she is the Care Coordination Services Manager in San Juan Basin Health Department. We're skipping around on your PowerPoint, and your PowerPoint Pam would be next. but Pam might have gotten stuck in the snowstorm. We're having quite a bit of snow here. So anyway, we're going to hear from Vanessa, and hopefully Pam will show up. So Vanessa, it's all yours.
Hi, thank you very much. We have the privilege of an executive director named Joyce, who's been here for almost 2 years. And before he actually started here as our executive director, he was working with one of the nurses here at the health department on figuring out what to do with 2 programs where the funding sources were going to end. So here at the health department, we had integrated child health program, and we also had the senior outreach nurse program, both of which were looking at population-based and infrastructure level work, and medical home was already hitting our community and gaining importance. And when we saw that those programs were going to go away, the nurse who was in charge of those programs here spoke with Joyce through some community meetings, and they decided together that they were going to ensure that something replaced those disappearing programs. And it took several years, but during that time, the RICO model was coming in. And is everyone here familiar with RICO, or should I describe RICO? Do you want to give any direction on that, Dan?
Yeah, I think that most participants should be aware of their RICO, but if you wanted to give one or two, go ahead and just describe what what RICO is in your community. But yeah, everybody should be somewhat familiar with that term.
Okay. So the RICO is the Regional Care Collaborative, and it has a strong medical home component to it. And for our community, the contract for the RICO for the entire Western Slope is actually Rocky Mountain Health Plans, which is an insurance company basically. So Rocky Mountain Health Plans has this RICO contract, and then they subcontracted with us, the health department. And that was largely because Joe and Kathleen had been working, and similar to what Don was describing, they had been building these relationships and having these discussions and getting people on board philosophically for a couple of years before the actual contracts went into place. So the RICO, Rocky Mountain Health Plan, they wanted to see that whoever they contracted with for care coordination services and nurse navigation services had the local support that would ensure its success. And so we ended up getting local support from our hospital, which is Mercy Regional Health Center, and also the County Department of Human Services threw in. And as well, we had a large pediatric practice called Pediatric Partners of the Southwest. And they all became funders, basically, of this new care coordination model. When all of those people came to the table, Rocky Mountain Health Plans, as the RICO, said, great, we will contract with the health department, and you guys can run this nurse navigator program out of your staff and using your resources. And so all of these people are coming to the table every month, and they're called the Oversight Committee. And if you could look at this little model I sent over, the blue circles is really where you kind of see the higher level organization and structure for this. So these boxes here are for the Care Coordination Services Department. We have the clients that are coming in. We have the services that we deliver to those clients, the programs that are structuring those services and or funding them, and then the provider, you'll see there the actual people who are doing the work. And so the provider list, we have the nurse navigators, and they are working closely with the HCP team, which also has a population-based infrastructure and medical home approach. And then added to that mix in our Care Coordination Services Department is the Parents Plus nurse. We have a promotora who's Spanish speaking, and the Healthy Communities Coordinator. And so all of those providers together are what we call the community care team of the Southwest. And much akin to what Don was describing, these folks that are on the ground, they look to see what the barriers are that their individual clients are facing in their caseload. They come together twice a month to do case conferencing. And in those case conferencing, they talk about these complex clients, they talk about the gaps and barriers, and they look for short-term or workaround or client-specific solutions within that meeting. But at the same time, I am there at that meeting. I keep track of what all these barriers are and the gaps are, and then I take those trends in gaps and barriers or anything that represents a systems-wide problem to the Oversight Committee, which is basically, if you look under that program box, you'll see the CCTSW, that's our Community Care Team of Southwest. You'll see the funders list under there. So again, that's the Rocky Mountain Health Plan, Mercy Regional Medical Center, Pediatric Partners, La Plata County, and then we have in-kind donations from our behavioral health system provider, which is Access Health Systems. And all these folks come and they sit at the table once a month. And what's been happening over the past year has been a pilot model. We're in our second year right now, and we're really, other than the funding that came together last year, this year is when we're really focusing on policy changes. So we just implemented our first protocols for the program, and we also are lucky in that our funders have identified that people that are jumping back and forth from Medicaid to CHP Plus is a barrier and a difficulty. Similar to some of those concerns perhaps that Boulder County faced, you know, we have a lot of support from Rocky Mountain Health Plans. So even though they have an insurance program where kids may be dropping on and off, we have the support of the top folks at Rocky Mountain and Mercy Regional that if we have a kid that drops off of a pay source, we still continue service for that person. They don't drop out of our care coordination program because of a funding source. And we have a lot of latitude in that, which has been really great because, as you know, kids will come back on, and it's very difficult to even know at the time of service on our side if they're covered or not. So we're able to just do continuous service regardless of what their pay source is. Those monthly oversight committee meetings, we come together, we've created policy. We also go through those barriers and we come up with solutions. Sometimes those solutions are a more detailed level and sometimes they're a higher level. A lot of the things that we're working on right now are memorandums of understanding for data sharing. We have implemented some agreements that allow us to do data sharing with other agencies in the community. We have access to the electronic health record system of Pediatric Partners, which is invaluable for not only for our nurses to see what the client history is, but then for us to communicate back to the provider that referred the client to us on what work we've been able to do for that client. We are currently, if you look under the clients box at the top, we are currently focusing on the CHINS client who's 0 to 21 years old. We're also looking at local folks. So San Juan Basin Health focuses on La Plata and Archuleta counties. We are a rural community, and so when we say local, what we also mean is that their provider is based here. So we do have folks who may live in a different county, but they're having to drive to Durango in order to receive care. And so we consider that a local client. We're looking at chronic diseases. Chronic diseases can include a behavioral health issue and then a non-medical barrier. And so we're very much focused on a lot of these social issues that cause people to drop through the cracks. So we do also have the latitude that if we have a client who's not particularly medically complex, but the provider says this person needs help, we can focus our work on them even though they don't necessarily look bad on paper. And so again, we have a lot of support, which has been really great. In terms of those memorandums of understanding, we're working very hard on getting that data sharing that goes back and forth between the providers. we are also unique, perhaps, to some other folks on this call in that we have a gap that includes the fact that we don't have a lot of specialists for children here. So we're 6 to 8 hours from Denver. We're 6 to 8 hours from Children's Hospital, and that's a major barrier for a lot of folks to get care. We offer the clinics. We do a lot of work around our rural population's barriers. And we're even working on getting some data sharing agreements in place with Children's Hospital. So we're having to reach a little further out than perhaps some folks have to in order to get those policy agreements in place. We are also tracking data that we are planning on sharing with our community. So a lot of our executive directors' goal this year is to collect a lot of data that we can then use to leverage policy changes in the next year. We are currently doing a lot of process mapping with our hospital, our local hospital, and the process mapping is what will hopefully ensure that the collaborations that we have get institutionalized and made into processes so that, you know, as staff turnover or programs change or whatever it is, that these processes that are catching the gaps and barriers and getting folks to keep relationships, keeping that communication together, that gets really hardened into practice and won't just shift with the winds. Jane, that's kind of the basics that I came with. Did you want me to speak to any other specifics?
No, I think that's a beautiful diagram, and you've described it very nicely. And I think the work is just phenomenal. So thank you so much. But we will open it up to questions in the chat room. You can raise your hand for Vanessa if you have any questions for her and her model in San Juan Basin. I'll let you type something in. I just wanted to talk a little bit about how this model that she's talking about has that policy hat on throughout. So it's just like what Dawn talked about, is that the boots on the ground are describing what it is that they're running into with clients and families in their communities. Then the services are being coordinated. So it's sort of a care coordination model for the services in the community. And then what policies were identified that needed revision or were ineffective, or that there needed to be some data added to that so that you could address it more systematically, or and then if there were recommended revisions, and then why you would, which ones of those revisions you would prioritize, or what ones you're going to maintain. So I think the examples that we just heard from our local communities have a lot of those policy questions in place, and they're addressing them. So it's really, really great work. Anybody want to ask Vanessa any specific questions?
You know, I have a question. This is Rachel. Vanessa, could you say a couple more words about your process mapping tools with the hospital? Because I think that that's a great example of, like you said, institutionalizing some informal policies into practice and making them more formal. So is there a tool or a specific, I don't know, steps in the process that you've used that you found helpful?
I don't have yes, I can. Okay. We don't have a particular tool in place at this moment. What's been happening so far this year, so from January until now, these past 4 months, we have been regularly meeting with different departments at the hospital to discuss the work. And part of that fits into your, I forget which activity it is, A, B, C, or D, but one of them has to do with working with the providers to educate them about the medical home approach. Yeah. So it's sort of hitting both of those at the same time. So we sat down together, for instance, at the hospital in a meeting with the caseworkers, with the social workers, and with the emergency department staff, the emergency department director. And so obviously one of the big pieces of this is transitions of care. You know, when someone comes out of ER, how do we make sure that they get followed up with, that they don't get readmitted, and all those sorts of things. So far we've been having regular meetings, and it's a pretty big endeavor because the hospital has so many different departments and staff, and they have outlying buildings that are in different locations. So we've met with the health clinic staff, and just sort of piece by piece we're going through and talking to folks and saying, you know, what do you need from us so that we're not duplicating services? How do we work well with you? And in the meantime, Will McConnell, who is a high-level staff person at the hospital, has been paying attention to all this, and he has regular phone conferences with our executive director so that we do have that continuum from, like you say, the boots on the ground up to the top. Our goal is to have this process mapping completed by the end of this year.
That's great. Those will be great tools, I think, to share with others if you guys are willing to just share them as examples, because it sounds applicable or transferable to a lot of different referral processes.
Sure.
Thanks.
So we're going to move on to our next speaker, Pam Kurth, and Pam is the nursing supervisor.
Program coordinator.
Thank you.
Yeah, that's okay.
I just had it right here, and I was looking for my sheet. Nursing. And she just came in out of the snow, and so we need to go back a couple slides. And I pressed twice, right? Oh, yeah. Whoops. Now I just ended it.
Scroll back.
Okay. Thank you. There we go. Here's Pam. So Pam is going to talk to us about her experience in Tri-County.
Which I haven't been here for the whole presentation, but probably will not sound nearly as positive as some of the others, which is probably why Jane asked me to come.
To balance out that positivity, right?
Struggles, right. So I'm going to describe my experience of working with RICO in our region, Region 3. So when the RICOs first kind of came up and started having meetings, at that time Norma Patterson was still working with Tri-County, and we thought we really better get in to see these folks and see these meetings and things. So we started going to some of the meetings. Of course, nobody was really understanding what it all meant anyway, so just learning what is a RICO, what is the ACCO, and stuff like that. So,
and for the benefit of the people on the phone, your RICO is Colorado.
Colorado Access for Region 3, which is Arapahoe, Adams, and Douglas counties. So it's kind of nice in that respect that our RICO has just the counties we work in, and not doing some other things outside of that. I thought, as they talk more about care coordination, I thought we really need to let them know what do we do at Tri-County and how can we partner with that. We don't really want clients to get two different sided care coordination and not really understand what's going on or feel confused, things like that. So I met with the person at the RICO who was really kind of in charge of all of that, and I went over everything that Tri-County did, and talked about all of our programs and how some of them, were very much care coordination programs like HCP and our Nurse Family Partnership, our Mothers First programs, things like that, how our Access to Care program helps get people connected to services they needed, and went through the whole thing, including all the other things we do at Tri-County and the immunizations and things like that. They took she took copious notes, and oh yeah, this is all great and everything. Never heard another word. So I kept going to some meetings, kept my face out there, and as I kept going, I realized, well, what they're really doing this first whole year is they're just really trying to get their provider network into place. They're not really into doing much care coordination, so I kind of backed off a little bit. But then as they started talking more about care coordination, now I don't know whether they were really doing it or not, but they start talking about it more. Then, I started talking more about it, how can we partner? We can do the same. We don't want to be doing necessarily the same things, We even tried to bring up conversations with them about, especially like for our Healthy Communities program as they start getting more children, and HCP, that, we're doing the care coordination, and we probably have some of your clients, why we should be talking about some of that. But it's just really been a struggle for them to really, I think, either embrace what we do or understand what we do, to feel comfortable contacting us about clients. I think most of well, they seem to be asking for a lot of information about, well, what are your processes for this or that, asking specifically in our Healthy Communities program, share your, how do you get the add babies, what do you do with missed appointments, what do you do with emergency room visit notifications and things like that. We always, of course, give them the information. These are our forms, these are our processes and things like that. But there just isn't very much, working back and forth, or even saying, oh, can you help us with this client or whatever. I think they thought we would be able to give them all their clients' primary care providers, thinking we have access to that information, but we don't have any claims information, so we don't really know who their primary care providers are and things like that. So it's just been really kind of a struggle to try and reach some kind of agreement. We've, even kind of said, well, we'd even go into something formal. Maybe you could even pay us a little money and we do it for you, or things like that. But I don't know if they're just not there yet. If there's so many things going on that they are trying to stay on top of, that, or what's really happening. So we just try to keep our faces in front of them and let them know. But it's I think it kind of boils down to also they don't really understand what kind of care coordination we do in our program, and their care coordination is probably a little bit different. And they've had to focus on such specific matrices that I think they haven't been able to look beyond that. So hopefully maybe this year they'll be able to see that. So that's it in a nutshell.
When I heard about Pam, this is Jane, going to the RICO meetings probably about a year ago, and one of my site visits to Tri-County, I was like, oh my gosh, isn't that great? Tri-County's like right getting in there ahead of the game and getting these relationships. And I was speaking with Pam about it, and I think it's a good example of maybe the RICO not being ready for a partnership, and us being willing to have a conversation about the partnership before anybody really knows where they are in the process. So I brought Pam just talking about, that it's a great effort, that she knew that this partner was out there, that she wanted to not duplicate service, that she wanted to improve the quality of services in her community for our focus populations. And now you have that relationship. They know who you are. They weren't even enrolling kids at the time that you were at the table. And so I just think it's a good example of sometimes how we want to mobilize these partnerships that we may be ahead of the game, but that our partners aren't ready. And but that's not a futile endeavor, that it could be an important endeavor in the future with having that relationship with the RICO, and that you've established that relationship and that people go at their own rate.
Hopefully they'll be ready someday.
Yeah, yeah. So that's, I give you kudos for, attempting that. That can sometimes be really difficult.
And I think they, frankly, I think they're very overwhelmed. I mean, they have a huge number of clients, and I think of all of they have 3 of the regions, and our region is like, I just looked at the numbers yesterday, and it was like 64,000 people that they're trying to manage and keep track of. So I think they're a little, overwhelmed maybe.
Sure. Just getting, like you said, providers hooked up and now clients signed up. So talking about partnerships is sort of a step beyond that.
Yeah.
Yeah.
So we'll just stay there and keep coming, and then they'll eventually, the light bulb will go on.
Sure.
And Kathy Bolichek comes a lot to the meetings too. So,
Kathy, I think you're on board today. If there's anything you want to add or ask? Anybody have any questions for Pam?
I'd be interested to hear if, like, Vanessa or Dawn or anyone else who's had interfaces with the RICOs, if you have any suggestions or thoughts, knowing that each RICO is its own kind of domain or kingdom. They have different ways of implementing their model, but if you have ideas around that too. I think Jane is completely right about laying the foundation in and building a relationship, because the RICOs aren't going away, so they're here, and how do we work with them and looking for that window of opportunity. But I would be curious to hear if anyone, and not just Vanessa or Dawn, but anyone has any thoughts about that, about Pam's experience.
So this is Dawn. I don't know. Can you hear me?
Yep.
Okay, great. So in Boulder County, we actually had a similar experience to Pam's, unfortunately. We put a lot of effort into trying to build a relationship with our RICO, only to have them really be interested in what resources they could get from healthy communities that had been paid for, honestly, primarily by local dollars, because in Boulder County, of the healthy communities budget, less than half of it is actually paid for through state or federal funds. The rest of it is paid for through a local tax initiative, so that we can actually try to better meet the need. So the materials that have been developed have been done at the expense of the local taxpayer base. So in our experience, the RICO was really only interested in trying to get those resources so that they could use them, but not in actually ever formally partnering. Part of it was that Boulder County is in the RICO where it was awarded to a local collaboration, and then the contract was contested, and then it was awarded to a separate private entity. So it was indeed delayed. So certainly that was part of it, that they weren't doing care coordination until just this last spring, and really were then only focusing on the highest utilizers, so not really impacting children. But we didn't, Boulder County I know is still trying at it to try to actually have more of a formal relationship, where ideally, as Pam mentioned, we would actually like the RICO to fund the local entities to be doing the kind of work with children rather than create a separate layer. But as of now, that still hasn't happened yet.
Mm-hmm. And I think for us, sometimes it's even the realization of what the what Tri-County can do. I mean, I think they aren't even really totally aware of the nurse visitor programs that make a huge difference. So. They do a lot of work teaching their primary care doctors about all the resources and things available. So it's kind of like, well, it's our job to teach them what other resources are available and what else is out there. I mean, yes, the money would be really helpful if we could partner and get money, but that's probably maybe not going to happen. But I guess just in the public health world, at least if we're collaborating with them in some way, is important.
Or even being able to identify, which, like you had said, which clients are in the RICO and which are not, and talking about how you divide and conquer and leverage your resources.
Right,
so
right.
It's like that process mapping almost that Tim Basin was talking about, like what's the referral process? Like right now there is no referral process.
Right.
It's like basically starting from ground zero. So.
Right, right, yeah. Yeah.
Well, this is Jane, and I think there's some of you that were at the Role of Public Health conference that the School of Public Health put on, and Ned Cologne was talking about how the role of public health, and that physicians kind of want to know all the stuff that we know, but they're never going to become public health, and vice versa, that we're never going to be the clinicians and provide that direct clinical care, and it was such a nice sort of simplification of making sure that we understand our benefits, but that we will never be the physician or the clinical aspect, and that they will never be public health, understanding all of the arms that we have in the community and where we can plug folks into better outcomes for kids and families, which is everybody's hope. So I think that was really a nice way to kind of describe that why we need to leverage each other and talk to each other about that we're not going to be them and they're not going to be us. Yeah, there's a nice simplification. Yeah. Anybody have any further questions for Dawn or Vanessa or Pam or each other? Molly Banker's here from Denver, and she has kind of a, well, she has a great new collaborative effort. And Molly, if you want to describe it, we have a few minutes.
Sure.
Do you want to come over here so that everybody hears you? Great. I'll just move aside and you guys can stay there.
They're right in front of the phone.
That's all right.
So I am one of the nurses from the Denver HCP office, and Jane asked me to share a little bit about what we're doing over in HCP. I just wanted to follow up with Pam's discussion on the RICOs and what we are doing, because we also are with Colorado Access, and we haven't had the success that you have had in meeting actually with Colorado Access face-to-face. We've communicated in emails, but Denver Health Managed Care is contracted by Colorado Access to be providing kind of the RICO support within Denver Health. So I've set up a meeting for May to be meeting with them to discuss exactly what you're trying to do, Pam, in Tri-County, to figure out where there might be some overlap and share what we do, decrease duplication of services, and really try to have a collaborative effort. So hopefully we can make some headway with that. So within Denver Health, we have a new CMMI grant, which is from the, I think it's Centers of Medicaid and Medicare Innovation Grant. And Denver Health was awarded a $19 million three-year grant to really look at innovations in care coordination for the 21st century. So they have are creating systems within Denver Health to look at the adult population, and I don't know much about what they're doing for that population. I believe it's, excuse me, really more focused on adults that are being discharged, but not for sure, and for children. And children are being placed into one of 4 tiers, with Tier 4 being the highest level of need that they have identified based upon ICD-9 diagnoses. There is some crossover with their Tiers 4 and 3 and even 2 for what HCP provides for care coordination. They've got groups of patient navigators that they've brought on that are really going to be providing a increasing level of coordination for families from Tier 1 up through Tier 3 by reaching out, making phone calls, reminders. There's also a group, I think in either Tier 2 or 3, of looking at children that have asthma and really doing some more intensive outreach with that population. But since this is right within our own institution, and we've got us as public health really sitting at Denver Health, which is primary care and serves as a medical home for families that are seen at Denver Health and seen throughout Denver County, really felt like it was opportune timing for us to work on increasing communication, collaboration, and integrating our program with the CMMI structure. And keeping in mind that we are not part of that grant. We, sit on the outside of that grant, but we do serve many of the kids that are seen in Tier 4. So for the kids that are put into the Tier 4, they have access to a whole multidisciplinary special needs clinic, which consists of nurse care coordinators, a physician, mental health counselor, PT, social work, and a patient navigator from Family Voices. So it's really a nice, comprehensive service that's being provided to these families with, I think, the hopes, I think the overall goal of the grant for adults and for kids is really cost savings. Whether that happens and to what extent in the children's population, we don't know, but I think providing this service really will assist families long-term in being able to access services and know who to contact and coming in for services. So within the HCP program, we initiated several conversations with the CMMI Tier 4 team. So we have been involved in some of their building of structures, creating of roles, discussions of where we might be brought in, and okay, if you've got nurses within the clinics that are providing care coordination, can we hand over some of the duties that we've been doing to you, and then we can do more of the community efforts. So it's just starting to get up and rolling. They've got, I think there's 4 or 5 care coordinators that they aren't all full-time, and there is a learning curve for some that haven't worked with special needs or with care coordination, but it's really an incredible team.
And you said it's nurse, all nurses?
All nurses. We're meeting monthly now. We had met twice a month, once in person and over the phone, to really discuss the structure, discuss roles, and to go over patients. And what I have noticed since the creation of this is such an increase in communication and collaboration, and we truly are part of that team now. So when emails are going to the doc, they're going to everybody on the team. So somebody says, oh, I can handle this piece, and somebody says, I can do this, and it's like, okay, if you need me to go to the home, I can do that. So I really feel like it's the beginnings of a wonderful integration of the program. We're part of their orientation, and they've come on home visits with us. We've been part of some of the rapid performance improvement stuff that creating their, having input into their forms, into their roles, into the basic structure. I think at one point we were really hoping that we could all use similar type forms, but it's pretty clear that their needs are very different from our needs and what we're required to do. But I think as time moves forward and as the grant moves forward and they create a system, we may be able to integrate into that system a little bit more so that the level of care coordination provided to families really is, what you want for a medical home. I mean, you've got the clinic nurses and their team, plus us being able to talk to schools, human services, the specialty providers, and really feel like we're part of a bigger team at Denver Health. So, I see this as a truly innovative just process that's happening right now that at least my personal hope is that it will be something that can be looked at as a true model throughout the state and be replicated in other settings. Even knowing that we've got such a wonderful opportunity with our setting, but something to really think about as we move forward. It's exciting.
Yay, Molly. Thanks for just presenting off the cuff, too, because I knew that what you were doing was was applicable to what we're talking about today, and that you really do have a lot of policy. It's that institutional policy as well as, you know, the way care is being provided and quality care is being provided. So it's a great example of what we've been talking about today. Anybody have questions for Molly? Comments like bravo?
Bravo. Well, you know, kudos really goes to Denver Health in applying for this grant and being awarded it. And it's taken some time, but things are up and going, and it's nice. And it's nice that we are being invited into it with the expertise that the Denver team has. So it's good.
A lot of workforce development going on with your orientations with the frontliners and how you can orient them to the community or not orient them to the community, and then you take over as needed. So workforce development kinds of stuff, nice. Anybody have any last comments? We'll give you 10 minutes, the gift of time, if everybody's ready to move on with their day. And we will be sending you an evaluation. A short evaluation of the participants that have been here today. I didn't give you any breathing room to answer that question. Anybody have any last comments? Do you want to move to the very end?
This is, go ahead.
Go ahead.
Rachel, I think it was earlier, said, is there anything that we would say to Pam? I would say that one of the things that made us successful in working with our RICO is that our executive director definitely met them halfway in terms of they have these cost saving benefits that they're looking for. They're key. They have the 3 KPIs, key performance indicators of decreasing ER costs, decreasing inpatient costs, and high cost imaging. And so one of the things that we were willing to meet them on that with is that we would track that data, and so we have a database system that we put together, and so we track those things that are important to our private funders. And then secondly, I would say that in order for us to work well with HCP, one of the things I've noticed that helped us succeed that some of our other RICO care teams are not doing is that we divided our nurse navigators up according to age groups. So we have a seniors nurse nav, an adult nurse nav, and a pediatric nurse nav. And by having that pediatric nurse nav sort of, you know, with a pediatric focus, it allows her, she's actually also our HCP nurse, but even when we've talked about models of hiring 2 people half-time, it essentially makes sure that getting the kids taken care of is an automatic integration. So just throwing those 2 things out there.
Okay. Thanks, Vanessa. Okay, well, like I said, we're going to send you out a few evaluation questions like we did for the last one, and I'm going to put in the evaluation, but would also ask verbally if you have any ideas for upcoming learning circles. We do not have any more plans for this fiscal year between now and the 1st of October because you'll be in your planning work and thinking about that, but we can add one if something comes up that a majority of people want to hear about or few people want to hear about. And we may have some just general learning opportunities yet to be determined. At the end of this month, I'm hoping that this expert's going to come into town and give us his presentation for free, but I won't even talk about that. I just did. And so anyway, the evaluation will be coming, and if you have any ideas for upcoming learning circles or how you'd like to learn together and what we can facilitate at the state, we'd be happy to hear that. So thank you so much to our speakers today, to Don Joyce in Boulder, to Vanessa in San Juan, to Pam Kurth in Tri-County, and to Molly from Denver. You've given us some great examples of how policy impacts our partnerships or vice versa. And thank you for joining us today.
Thanks.